Panel discussion, primary health care management. Good afternoon, this is 100% Tatarstan. We discuss primary management of the primary medicine. And here we have Mr. Sadikov, Minister of Health, Republic of Tatarstan, Albert Galevich, academician of Academic Science, head of the Department of Cardiology, Kazan Medical University, and chief cardiologist of Volga region. Ayrat Zaidinov, deputy of the State Council, Republic of Tatarstan, the head doctor of Republican Children's Hospital. Sergei Savinov, head of the Polyclinics 10. Gennady Glushko, deputy of the State Council, head of the insurance company Spasenia. And we also have Mark Sluter from. Can you hear us? You can join us anytime. Our discussion. And Ayrat Farakhov, deputy of the State Duma of Russian Federation, doctor of medicine. Ayrat, yes, we're very happy to have you with us, and we'll be very happy to have you as a part of our discussion. So, probably the first question to you. We would discuss these important topics about the primary medical health, and we talked about it before this problem actually became very important. So let me remind you that in the national project we had the necessity to use more resources, to pay more attention to primary medical care. We're talking about 500 billion rubles. Now, well, we learn more, we understand what is high quality primary medical care. Where do you see your weak sides and strong sides? Well, thank you very much for your question. Let me just explain a little bit what is the management of the medicine. What we mean by management. One thing is management in the industry, management in other industry, but management in the medical care system. It's all about controlling and organizing resources which you have, and it's exactly what we do in our healthcare system. It's decreasing costs, decreasing our losses because we lose people's health, and if we don't pay attention to the medical care. I wouldn't probably separate medicine as preventive medicine and medical care, medical help which we provide in the hospitals. We do have some common criteria. Whatever type of healthcare system we implement in Russia or in the Federation, the main indicator of quality is the life expectancy. That's the main indication, and mortality, rate of mortality. Well, we understand that it's okay with lifespan. Yes, we increased significantly lifespan for the last 10 years, and this increases in 4 years, and now our average lifespan is 75 years. Well, the mortality rate, it's very, very important, but it depends on a lot of criteria. In 2019, we managed to provide the lowest mortality from 1991. And if we talk about primary medical care and hospital medical care, first let me tell you that previously we paid more attention to the hospital care.
And primary medical care was stagnating, was not developing as quickly as a specialist working in the inpatient clinics are better qualified. Secondly, there was an opinion that working in outpatient clinics is not prestigious. We were surveying students as well as graduates. Where would you like to work upon completion of education? And 85% said that they would like to work in the inpatient clinics. So that kind of stereotype was formed not only at the level of citizenry, but also among the doctors. And we need to change that perception because, first of all, patients are going to the outpatient clinic. Only later, at some stage, they're getting into the inpatient clinics. So seeing this, myself as well as my predecessors over the course of last 10 years have decided and been working on modernization of the primary medical care stage. We were the first ones to start, and the respective programs were initiated in rural areas as well as in cities. Over the course of the 10 years, there was this presidential program. We have repaired over 1,600 nurse points, over 500 new primary medical centers, and in that sense the structure and the infrastructure is different in the rural area. After that, the modernization of the all primary centers was organized, repairing our outpatient clinics, over 129 polyclinics, not only for the sake such as doing the capital overhaul and equipment modernization equipment-wise, but also directed at providing for a good provision of staff. Different programs, be it at the federal level or regional level, have been developed to incentivize participation of doctors and nurses in the primary care level. This is exactly how we see we can address decrease of mortality, improving quality of life in the region. You mentioned that your graduates want to work in the inpatient clinic, so for them working the outpatient clinics are less attractive. Well, what other things that young doctors want? They obviously want the prospects of fast growth in career ladder, young ambitious. It's also important that we will be developing primary medicine just like the inpatient clinics. We can't afford having inpatient clinics being the head and forgetting about the primary healthcare provision. Back in Soviet Union times, there was an interesting model in city oncology service. The model that was operational there, inpatient clinic was having its own medic ambulance services as well as outpatient clinic. In that sense, doctors were rotating, working in the inpatient clinic and outpatient clinic, working in the ambulance. That was a wonderful model, one of the best models when we were showing integrated work, when the specialists were well aware of the type of work in all points. But that is dependent on the specifics of geography of the region to be able to run such a model. Who works in the city outpatient clinics today? How is that working? Back at the time of Ira Zakievich, if I'm not mistaken, in year 2008, they started developing small medical complexes when small outpatient clinics were being linked with large inpatient hospitals. Thus, that was creating a pool of financial and human factor resources, and that model has shown itself to be effective, such as in city Seventh City Clinical Hospital. We have piloted that, worked it out, and that model was being applied in other places in Kazan as well as in our other towns and cities. We can't, of course, cover whole of the Republic that way, but I can give an example of another model that we started seeing in the year 2014-2015, when we see a large polyclinic in the center that is linked together with a smaller polyclinics, all together being a single legal entity, concentrating financial and staff and material resources available. We obviously can't have a CT installed in very small clinic. We are looking at different models that allow us to satisfy the needs of the local population. Redzaki, the minister comments on your experience in the position, and what do you see as an opportunity for strengthening training and accessibility of doctors, because we have all seen the importance of doctors in the latest month. Thank you very much, Elena. You have touched the primary medical care segment, most important from the point of view of healthcare provision. And just remember about the last year and a half, 2 years, three times was addressing, and twice he said at the Russian Federation level there was a drawback. If I remember correctly, it was in Usman and Lipetsk district. He said that the primary medical care didn't end up being the way we imagined it many times. I'd like to draw attention that Tatiana Alexeyevna was drawing attention to this, stating that optimization of healthcare that was run in the country was not successful in some over 50 regions subject to the Russian Federation. Tatarstan, one of the few regions where optimization was done as an optimization, not as cutting down costs, but looking for a new quality results. In this sense, in Tatarstan, it did evolve into a new state, including the primary help. So obviously the question is, what should we do with whatever challenges we have today? Fundamentally, obviously that is based on the new renewed constitution. We should be following the pathway of providing quality and accessible health care. How to guarantee this at the primary level? Well, professions of doctors and the primary step, especially in the rural areas in such a country as Russia that has very large rural territories, should be attractive. Younger doctors as well as mid-age doctors are not willing to join those positions because at the moment it is related to lots of bureaucratic reporting procedures unrelated to individual decision making. It's not as attractive financially, and it is not providing social benefits that are available to doctors at the inpatient clinics. I believe that those issues need to be addressed. Many doctors are choosing to work in private sector because in the state sector there's a very high level of administrative responsibilities, whilst the income level in private medicine is much higher. We need to work to increase higher tariffs for payment to doctors that would provide us with the possibility of getting higher wages to doctors. Let us remember healthcare in France, because in case of the payments that they get in case of rural areas, it's plus 25% to anything that budget contributes. In that sense, I would like to consider a different form of primary stage doctors. We've been discussing this with you, Evelina. We have talked about active development of self-employment, which is not entrepreneurship, but at the same time it is not a regular state of affairs being an employee in the Russian Federation. If we would consider separate elements of this legal status with increasing wider qualifications for the primary medical professionals, for them to have a wider spectrum of skills, including neurology and ear, nose, and throat, they would be covering an important segment, including primary identification and routing of patients. That would be very important for us to increase the attractiveness of positions of doctors at the primary level. And we obviously need to reform medicinal provision system as well, because without that system, the administrative burden is once again shifted into the shoulders of the primary segment doctors, outpatient clinics. Tatarstan seems to be developing quite well in the topic of digitalization of hospitals, something that is not advancing in the Russian Federation overall. If previously that was done at the hospital to hospital, at large hospital centers, right now we need to be taking this down to primary, making sure that respective gadgets that are helpful in this are accessible to primary stage medicine professionals. Just a few things to enumerate. And also working in the State Duma as a parliamentarian, I believe that any kind of changes that we expect to have, it's important that they are backed by the acts of parliament, because other decisions, even at the government of the Russian Federation, are not shaping the environment that we need. At the moment, healthcare at the primary level is not developing because there is no legal regulation, no legal frameworks. Once there are no such, there is no mechanisms for justifying your steps. In that sense, it's important that we prove and strengthen those with the acts of parliament, and I'm quite confident that private sector would obviously be happy to help wherever the state doesn't have money, etc. Well, I started thinking, who would do that if not you, the parliamentarians of State Duma? And for us to have you as a person to comment all of this, the complex of measures that you have described, it seems to be quite reasonable and workable. Let us break it down into, I don't know, a set of legislative actions, norms, and arts. It seems that, look, there is now this amendment in the Constitution that the medical care should be accessible to all, plus talking about the accessibility and funding, because those, 500 billion rubles that were allocated as a help to primary health care, they has not reached the in professionals down to earth. That is now delayed to January and February. What can people be doing here locally to speed it up? Healthcare protection authority is transferred authority, and the main funding for this are the funds coming from the system of mandatory medical insurance. Clearly, that funding is not enough. We need to admit that the healthcare system has not been funded to the necessary level. At the same time, there are certain reserves which were mentioned by Mr. Sadikov, the Minister for Healthcare of the Republic of Tatarstan. Many things are regulated by federal authorities, and execution is always local. And federal authorities are unable to question those things, to check on those things. Locally, there are always contradictions related to the fact that people don't know what to do due to the reason that their hands might be tied always, quite often. In Usman, in the Lipetsk region, the president also spoke about the municipality is decision making at the municipal level, but at the same time we have to admit that municipalities today don't even have money to fund any of the municipal clinics. Despite the most complex situation with the budget, public health care provision should not be decreasing, and it's important for us to find opportunities to keep the programs that we are running. Talking about the modernization of primary health care, I wouldn't want those 550 billion rubles to be directed at painting walls, buying furniture and equipment, because it's self-evident that the polyclinics we were proud of in the Soviet era, to some degree, is aging. The concept that we need today is different. Polyclinics that would be much closer to people, would be more family-oriented and less costly. The main person in this polyclinic should be patient, and his or her helper is to be family doctor that wouldn't be responsible for routing but would have a chance to have independent decision making. I would like to continue. The country we are living in, Russia, is large. All the region subjects are different in sizes, in situations they have. In that sense, it's inappropriate to be using one template and try to use one-size-fits-all solution. Tatarstan is quite developed region. We can use some solutions that are applicable to Moscow region, Nizhny Novgorod, St. Petersburg, whilst other territories behind Urals, especially where the regions are very large territorially, they would need probably different models. The same second comment of mine would be healthcare has not been funded at the level that we would wish to. At the moment, I would like to see that chronic underfunding will earlier or later lead us to some acute situations, some recidivism.
We met with Arat many times. Minister of Health said that our hands are tired. We cannot make the and federal budget. So every patient has a right to choose a doctor, and there is some kind of a dissonance, a disproportion. So we still have this previous system of healthcare, and we have representatives of all levels medical care. In old system, we had special a lot of different things in the primary medical health care, and those polyclinics which are competitive. Every patient wants, of course, to deal with this advanced polyclinic, and before that we didn't pay enough attention to we have a lot of people who come from rural area to live in the city. So people are registered in the rural areas but live in big cities in Kazan, and so they go to get medical help here in the city. So we have to analyze all these changes, demographical changes. We have a lot of them, and we have to take them all into account. And we have to see in the future what will happen with this or that region. Probably we have to change something in this model when the primary medical health is provided. We get the budget money per capita. If somebody feels sick, goes to the good polyclinic, and it's just this balance between financing of different polyclinics. Shall we listen to the manager of this polyclinic? Well, let me just continue. And prestige of or reputation of the polyclinic is just going down. I mean, it's been going on for many years. I am a surgeon, urgent surgery with a 15 years experience. Yes, after university I wanted to go to the hospital, for inpatient hospital, and just and doctors who couldn't find job in the hospital went to polyclinics. And doctors didn't want to work in polyclinic because we had to go to the patients who couldn't go to the hospital. And then after 4 years, 4 hours of working day, the doctor had to go to the patient. And when I look at our polyclinic, and I have been working for 7 years in my polyclinic, and it's just difficult to believe. We had almost 80 doctors came to us, and there are pluses and minuses working in the hospital, and there are pluses and minuses working in the polyclinics, night shifts, and we don't have night shifts. But 5 years ago, 2015, Ministry of Healthcare, Republic of Tatarstan had a project. We supported this pilot project in our polyclinic. When we got paramedics who helped doctors, they use our cars, medical cars, to go to the patients who are at home. And a lot of people understood that it's better to work in the polyclinic because they accept patients in the polyclinics, but paramedics visit patients at home. And during the time we got 18 more paramedics. Problem for minister, it's important information, because before the paramedic on the ambulance can work only on the ambulance, and now we have this unique opportunity for paramedic work in the polyclinic as well. So now we have 100%. We don't have any vacancies. I mean, we have everybody. All doctors what we need. Now I'm not really happy about it. We have some federal laws and regulations, the old ones, and how many patients should be per one doctor. We have 7 surgeons. That's a lot. Doctors in one polyclinic. But for 10,000 people, we have to have 1 surgeon. And it's everywhere in cardiology, neurology, and the area which serves 1 doctor. And for the last year, when we say that according to federal laws and regulations, we see that the new laws, and we see if we have enough resources. Well, thank you very much for the ministry. We could hire more doctors, and we managed to survive. I would say that we started redistributing our doctors in the organization structure of the hospitals, and we see what's going on, and we see that we have the migration of rural people into the cities, and we have the central agglomeration, which is Kazan. We see the demographical situation is changing. Then we see what's happening in the southeast area, and during many years we didn't reconsider, we didn't review our organizational structure of our hospitals. And but now we see that the situation in polyclinics is changing. The question is that again we have to reconsider again the organization of the hospital. We still continue using the methods which we used in the Soviet Union, and so we see like for 40 beds in the hospital we have 2 doctors. Or look at the polyclinic and the number of districts which polyclinics serve and how many doctors we have per one district. And from polyclinics I just disagree what's going on right now. The model which we used to have when the took narrow specialists from polyclinics and sent them to work in specialized hospitals. But now the rules of the game have changed, and we have to return narrow specialists to the polyclinics. We have to have all range of doctors in our polyclinic. And we have to be flexible in terms of choosing how many doctors or what kind of specialty we have to have, depending on what kind of people we have to serve. And where are you from? What district of Kazan? No, adult people. It's just like more than Bugulma city, more than Zelenogorsk city. How much time does it take to get appointment to the doctor, depending on what the specialist? Well, which one is the most difficult to get appointment? Well, they're all not easy to get to. Okay, when all doctors are in place, we're doing okay. We can provide guaranteed medical assistance. Well, if the patient needs to get to the general physician during the 24 hours in polyclinic, it is not easy to do. But we have the emergency appointments when patient comes without official appointment. We have 3 offices where he can be helped. I'm telling the truth. If I decided to go to your polyclinic because I was told that it's good polyclinic, so if I come to you, if I get the appointment, how long should I wait? I'm asking you not just to ask you. I'm asking because we're discussing the management of the primary medical health, and we want to understand. These are the people who make decision. How can we make patient happy? Because we all work for the patients. There are specialists to which you can go online and get appointment, and to the therapist and so on. There are specialists to which we don't have online, like oncology. No, you cannot do it. Before you go to oncology, you have to go to therapist. Therapist filters patients. If therapist has too many patients or doesn't know what to do, he just asks for consultation. But we have most doctors of most specializations. We have problems with the narrow specialists. Like what specialists? Like, for example, like cardiologists, for example, the ophthalmologists. I mean, all neuro specialists. Well, but we have special medical centers like hematologist center, rheumatology, gastroenterology center. So we have some budget quotas to help people. My two colleagues named two different models about possible modernization of the primary medical care. You listen to these things and you understand that you will have to deal with which model is better for you. What exactly you need? What do you need? First of all, we have to understand how these resources, which for patient, it's not interesting to listen to these models and everything. Patient needs to see the doctor, and to make it available and accessible, we have to understand how many doctors we have. It doesn't mean that you have 100% doctors in place. Maybe it's just half of what we really need. Yes, we have to review it because situation is changing, and maybe some things not possible to do with the resources which we have. But you do understand, you already said that we do not have enough doctors. We have to, for the 6 years, I think, and we just, with our HR department, we probably, the rotation is about 80%. We have a lot of new, young specialists. On one hand, we have 45 of our doctors are in maternity leave. And this is, 15% of our doctors are in maternity leave. Can you imagine? So it's so do you have more males or females doctors? Yes, we have more females doctors. Two more things about polyclinics, because I'm a doctor with big experience. Two important things. It is, of course, we have to decrease the working load on the doctor, because 2,000 people. I mean, we have an example. One of the polyclinics, we have 500 people for one doctor. Morbidity decreased, mortality decreased. Doctor must have time for self-education, for family, to have rest. Doctor must live normal life, and you have to provide polyclinics with better diagnostics as possibilities. Why doctors don't want to go to polyclinics? Because they don't get any professional satisfaction. They cannot develop professionally polyclinic. But if they have access to computer tomography, to ultrasound examination, I mean all this. So diagnostics, the outpatient diagnostics must be very close to the inpatient diagnostics. So that means the doctors will be able to learn more, to improve their professional knowledge, and provide better diagnostic services to the patient. That's what you have to keep in mind. Arat, you know that you are busy now and you have to leave our discussion. Could you please sum up our discussion? Would you please tell us what regional initiative you, as a regional deputy, are ready to promote? Thank you, Evelina, very much. I would like to answer your question. Why? It depends on our deputies, especially in medical care system. As I remember, before New Year, in December, we talked about it. Parliament accepts 1,500 laws, and only very few of them were about medical healthcare system. Of course, Parliament must consider more and pass more laws, but after they agreed with the President administration, with the government. Anyway, if we talk about serious structural changes of primary medical care, we need political will to do these things. Of course, we can we can make little changes and go little steps. But if we really want to change the big picture, we have to change laws, and we have to, of course, get the agreement of all interested parties. Well, it looks very easy. It is obvious that now we have to promote telemedicine actively, but Ministry of Healthcare does not support our federal law, and it's pretty obvious that in Russia is a big country, and regions of Russia has very different level of medical development, and we can save a lot of money if we develop telemedicine. We can save our resources. That is why we have very serious work ahead of us. But I would probably promote the really serious transformations of our primary medical healthcare system. We could really do a lot, but let me just underline again, the possibilities for the subjects of federation are quite limited. And here on the federal level, it's important to approve new concept of the primary help, and I think that this reform, this change will finally become successful. We do everything what we can, and I'm ready to support all your ideas. The main thing for us is to keep and stay within this budget which we have for the next 3 years, because the situation with the budget is not good. The income of the budget is not what we had 2 or 3 years ago, and the budget will be reconsidered, and it's very important to keep spending money on the medical care system, even probably increase, because it's about people. Irat, remember your promise to me not allowed to decrease budget spending on medicine. As for the telemedicine, which you told me about, are you talking about the possibilities of the primary medical help and improving it? Yes, it took us a long time to approve this law about telemedicine, and we have a lot of changes in it. And formally, now telemedicine cannot be used everywhere. But situation with the COVID crisis showed that telemedicine is an important element for healthcare. And now, if we were using it more intensively, it would be better. We are lagging behind the rest of the world. We could save time of our specialists. We could save resources. We have to approve laws, and we have to allow using telemedicine everywhere. But for a number of reasons, it's just doesn't problem. I like this discussion which we had, and we noticed that we see, but there is one important thing.
When you're talking about engaging patients with their outcome, and in that sense, patients can achieve much more with the support of doctors and nurses. But please remember that primary help is very important, and that could give better results if we give patients the opportunity to monitor their health from home, especially at the time of pandemic. In my case, some 20,000 patients are interacting directly from home. In that sense, as it was already said, there will be less load on doctors and nurses. It will be like delegation towards doctors. It's quite correct, sir. Could you please describe the way our project is being implemented in Tatarstan, I do understand that originally the primary consultation was supposed to take place between the doctor and patient, and we were talking about the observation throughout the course. In our project, it's organized as a prophylactic preventative program when we are stressing attention on patients among whom we disclose the risks of cardiovascular diseases. We are working, 38 clinics are connected with the help of Ministry of Healthcare, and we noted that we are capable of disclosing diseases at early stages that we didn't even know before. That is taking place after dispensarization. We start having some monitoring. That's another important aspect that needs to be organized and funded, and that's not only in Tatarstan, in Netherlands as well. And the step of what we'll be doing with patients post-factum is important. You might know that we are having a decrease in mortality in case of people because a proper process are taking place. This important process need to be stressed, and the new scheme is organized using with the state medicine. In that sense, if State Duma can adopt that draft bill and turn it into a law, that will be an important step forward. In that sense, nurses and patients and doctors would be authorized together. In that sense, we are not reinventing the wheel. There is a very good experience in telemedicine in Europe. There are some laws adopted in telemedicine there. So for some reason we are choosing to stay behind and then start to act, heroically to address those issues. We are thankful to the President Minnikhanov to support the pilot project that is being run together with VTB Bank. It got funding. It would pilot the result. We should get the results that patients don't have to walk or to ride to the polyclinic, getting accessible teleconsultations. That way, saving their own time, the time of other patients, etc. In principle, there is nothing difficult to organize this, so it's a question is about funding as well as remuneration of doctors as well as responsibility for consultation if something goes wrong with the patient. And you can't resolve that at the level of region? Yes, I understand that you need a federal law that is setting that limitation. Yes, there are plenty of pilot projects, but it's the law that decides. How did you increase the number of telemedicine consultations 5 times? Were they the doctor to doctor or doctor to patient? Doctor to doctor, but mainly doctor to patient. You know what? Pandemics has shown many things. That there are plenty of analytics that we can have. A significant share of telemedicine seems to be in the gray area. Yes. Many patients had to become specialists in virology, in cardiology, in infectious disease, and pulmonology. They read so much, got so many consultations that with some we can speak at the same level, and all the political leaders, heads of many region subjects, when you watch the TV, they are speaking at professional language. You are somewhat ironic, I feel it, but I think that patients choose to contact a doctor they know through WhatsApp or Messenger and get the same consultation, but the doctor is spending their time that way, but they obviously, humans, they wouldn't reject, and that's not, and they're not rewarded. Well, it's better if patients would be getting medical help and not just reading on the internet. Mark Twain has said, don't treat yourself by textbooks, you might die out of doctoral mistake. In that sense, it's clearly telemedicine should be legalized. The respective remuneration should be described, as well as documentation of how that is to be done, as well as quality analysis. And in case of doctor-to-doctor consultations, how are they organized? You have a good example, don't we? We as TV channel are being contacted by patients from various regions, and we are trying to organize a telemedicine consultation between federal center and regional center. When the colleagues are coming together, in cases of cancer, most often, and telemedicine consultation is not very much desired by regions. There are situation centers in Republic's Clinical Hospital and Republic's Children's Clinical Hospital. In the time of pandemic, we established a situational center in the Republic's Clinical Hospital. First, for the contacting from other clinics throughout the city or at municipal districts. The most challenging patients are being consulted through telemedicine with participation of all the specialists of Ministry of Healthcare, as well as outside specialists. In complex cases, we were even connecting federal centers, and we were having a joint work. How are you getting funding for this? This funding is already earmarked in federal centers for federal level topics, and if some central municipal hospital is getting consultation from the Republic's Clinical Hospital, it's free of charge. So any doctor of Republic's Clinical Hospital doesn't have any challenges with diagnosing or would like to get an advice or a second opinion would need to contact a doctor at the federal center. It doesn't need any kind of rewarding, does it? Let me give you a simple example. In case of cardiology, we are subordinate to Almazov Center in St. Petersburg. Getting in touch, how many cases do you have a day? Not that many. It is recorded how many patients, but not only consultations. After consultations, we can even transport patients over there. I know that there are these opportunities. That is done free of charge. Free of charge for the patient as well as medical institution. Ayrat, could you please share about Republic's Clinical Hospital of Ministry of Healthcare of Republic of Tatarstan? What is primary healthcare? What needs to be improved in there? Well, a modernization of healthcare obviously improved the medical and technical equipment of the institutions, as well as improving staff qualifications, as well as brought various innovations and novelties into our work. In childhood, most important topics would be bringing in lean technologies in the medical institutions that decrease the wait time, decrease the number of inscription, getting appointments, a proper routing of patients. That way, that led to the increase of satisfaction that our patients show in medical health. And latest surveys are showing that up to 86% of patients are satisfied in childhood-related medical institutions. Lean technologies are very much making it easier, simpler, and more comfortable to work in these conditions. When conditions are optimal for both patients and for doctors, that is an EQ as well as appointments, as well as the workstation, as well as personal accounts for patients. That simplifies the work of the medical center operation as well as for doctors themselves. If I remember correctly, at the time of Arazakevich, the model was established, which became very effective for the Republic. Children's Republic's Hospital, yes, they had a polyclinic, consultation, a center for consultation. That was a third level, and the people were coming for consultation, to get consultation for children. The model that was offered gave a chance to obtain consultations for patients that were coming to larger clinics. They went around the city. At Azina Polyclinic, when that polyclinic didn't have enough staff and significant population body, so having both scientific material as well as staff, in the Children's Republican Hospital, has that experience led us to raise to the unprecedented level. This year, we ran a pilot with the permission of our president, Rustam Minnikhanov. We took Children's Republican Hospital and connected Central District Hospital with their primary networks, including those nurse practitioners, paramedic centers. We want to pilot that, and if we get positive results, yes, we have chosen a district with the lowest staffing levels, highest mortality for population in that municipal district, with the lowest funding and material provision, legally set up the framework, and the specialists of their institution gets supporting the territory, postgraduate students that are going in that territory and analyzing patients that were somehow getting into the clinics before in different ways. They are now getting consultation by the doctors of Children's Republic Hospital. At the same time, the municipal doctors are getting, say, internships, as well as getting mentorship from higher level specialists, more qualified specialists coming to the district, which leads to improvement in the services. On top of that, the program that we have started implementing in line with the program supported by President Minnikhanov, coming to villages irrespective of number of their population, doing dispensarization, collecting analytics, being able to understand and manage risks related to cardiovascular diseases and others. We have to prepare not just the regional passport, but passport per the population of every municipal district and what should be done there. In that sense, we are organizing a vertical support or sponsorship of an institution in the capital with municipal districts in healthcare, mean not just financial and material resources, but also human resources are concentrated in larger institutions. In this sense, that kind of one-to-one relationship allows for high-speed support immediately post-consultation through the services of situational center is there is a decision on whether to keep a patient locally, transport them to the capital. We started doing similar things on municipalities and cardiovascular diseases. We started seeing certain competition, and we are drawing the results on how the main indicators of mortality have decreased or increased as a result. Yeah. Is that decreasing? Yes, I can give you an example. A region that had such vertical support, within 1 year of such a program, mortality decreased by 13%. No, the short link is the answer. Once you get the phone, internet, other connectivity, analytical work, that's methodological work and consultancy. All those components are significantly improving the outcomes. It's basically analysis and joint analysis with all. Our colleague from the Netherlands has spoken correctly. That project is piloted for over 2 years now. We call it risk management. May I ask a few more questions before I choose to move to Tatarstan as a mom? I would like to ask questions to the head of the children's hospital. How much time do you have per patient per child? Up to 20 minutes. And for example, right now there is dispensarization. How can I get an appointment? You can get an appointment with physician in the course of 24 hours, and if dimensions, you get inscribed, you can get an appointment. You can get not just an appointment, but you can go and have an appointment. I told you, lean technologies and call centers allow for multiple channel of getting access. Internet, telephone, as well as in person. We are shortening this appointment allocation, and within 24 hours for physicians or 48 hours for narrow specialists. Talking about Children's Clinical Hospital, we have 100% staffing with doctors, nurses. In Children's Clinical Hospital, we have everything to address the tasks we have in place. So the last question of mine would be, what are you missing? With the great support of the President of the Republic of Tatarstan, Ministers of Healthcare of the Republic of Tatarstan, we are having different programs, both to fund the equipment, both technological issues, as well as introducing different programs. In childhood, we are quite satisfied. I think telemedicine is actually very much necessary dimension in the children's healthcare, because all this infectious diseases, etc., you seem to understand everything, but it's important to get the recommendation of the doctor, specific drugs, etc. Once you hear doctor's attention, you can calm down. That is being actively introduced. We are talking about staffing. But there are different figures per capita in national project. That's one of the indicators, the provision of doctors per 10,000 per capita.
And we got that, we analyzed, we took into account those were the people, the doctors who work in medical facilities. I think it's completely wrong. Again, we have different subjects of federation, and in Tatarstan we have a lot of private clinics which participate in the government procurement, and they provide medical assistance or medical services. Second is that we have big shareholding companies we have some medical facilities like police, belong to police, FSB, the railroad companies, they have their own. We have 12 city hospital. If we put it all together, so the number of doctors is well, thank you very much. Please join us our discussion. Join our discussion. Probably I will continue talking about the primary medical care because in my company, insurance company, I have insurance company. We have polyclinics which participates in a private-public partnership. IRAD was kind of godfather of this initiative, and and it was at that moment really real experiment. It was 2012, and it was the experiment is still going on because not all issues are solved. But I want to tell you that this is one of the forms of modernization, and it turned out to be good, efficient, and the state got private investments, modern management, then we got services which not all municipal polyclinics can provide because of the tariffication and financial limitations. We have to, in this tariff we don't have, because we compete in equal same conditions, and we have to look for new attractive services. We have to decrease cost of management, cost of monitoring. So this is what helps us to model and to have to have something, to do something for the transformation of state medicine. Sometimes we don't have money, not because we don't have a lot of money, but because we cannot manage it. And in this case, coming back to our conversation about telemedicine, we had to use this form of medical care, especially during COVID. On one hand, it pushed us to decreasing morbidity among doctors, and we had about 80 contacts a day with the COVID-infected patients. At the same time, we streamlined the appointments and everything was fine. I want to say that we're talking about public-private partnership. I want to say that, and I want to thank Minister of Healthcare that, and today I talked about it, that we had a lot of limitations of the organization of the hospital, and we had some laws, still laws from Soviet Union. Yes, we follow laws and regulations, we fulfill them, we administer them, but at the same time we have more freedom. We get a tariff and we have possibility together with the Ministry of Healthcare. Ministry allows us to do this kind of work. Well, our priority is to fulfill all requirements, but at the same time we have freedom to choose with a different polyclinic. We have our own quotas to use high technologies, and for our insured patient, it allows us to participate in competition with private businesses, private hospital. We do not participate in these programs. I want to say that the full tariff, I don't know if there are any polyclinics apart from ours which provide such scope of services. I don't know. But I believe there are some, at least after your program, after our panel, we must have them. Coming back to insurance, we always work during reforms, and when we talk about them, discuss them, especially after COVID crisis, federal government and Council of Federation, they all started talking about next reform of the medical insurance system. They say that we must not destroy it, we must modernize it, we must take everything positive into new model and make it really, and make it really insurance medicine. So we all have to, state medicine and private medicine, which takes part in the government norms and regulations, they all have to decrease their cost and their risk in order to fulfill the state guidelines. And I think that it will be very progressive, very good solution to improve quality, to develop competitive and improve competitive environment in the healthcare system in the Republic of Tatarstan. Well, we hope that this cost reduction will not decrease the quality. We still have KPI in mortality and morbidity. They are important for all of us. We have different opinions, and we discussed the direct financing as opposed to the insurance financing. Yes, there are a lot of pluses and minuses. When you started this polyclinic of the primary medicine, did you have any polyclinics in the vicinity of yours? Well, we opened it on the basis of already working polyclinic. No, we did not show up from nowhere. We had polyclinic already working, but the original impulse was that we had a private clinic very close and state hospital, government hospital. We just transformed it, reorganized it, and we gave possibility for people to get their services for money. X-ray, mammology, and other services. All our patients, official registered patients, they use all these services for free. If I understand you correctly, did you understand? I understand correctly. We discussed a possibility of private business to participate in state medicine, government medicine. Как мы now, let me answer. Now, as my colleagues said, there is no such possibility to work. And there is no possibility to invest further because it always very risky, it is very unstable. And by the way, after constitution reform, we will continue introducing changes in the law, and we will prepare all of them. We will all clarify the definition, what is accessible medicine, what is quality medicine. And I think it will be very important because the vector, so that the private organizations, but state-funded organizations continue working. It's a good idea. We have to support them, and we have to develop it. But we have to provide conditions, and the competition. Competition is always good. Competition decreases cost, decreases prices, helps to provide high quality service. And I believe it's important. Competition must not lead to bankruptcy. because people might find themselves in the situation without any primary medical health. So we have to find a reasonable balance. There are not many such organizations which can provide all scope of medical services. If we talk about fair competition, a lot of private clinics which provide marginal, profitable medical services, it's not good. They have to take care of some kind of a social responsible services. We're talking about the urgent medical care or diagnostics. But what my colleague proposes, this is true. This is correct. And let me add some more. We discussed a lot, and our ministers always mentions this on different meetings. We have to unify our standards, all medical reports in all medical facilities, including private sector. I am from private sector, and I support this idea because absence of standard legal basis in every way, in all directions, and for different categories of people, for employed people, unemployed people, children, it's difficult to provide correct tariff calculations because we double. I mean a lot of. We confuse tariffs. Confuse tariffs from private medicine and state-funded medicine, and that's a big problem. And we really have to address this problem to the government. The rules must be the same for all facilities which got the license for medical. Provide medical services, private and state-funded. It just happens that we somehow influence on the private clinics, but the ones who don't have this license, and we have some inspections. We have to check them and inspect them, and we have some. Controlling authorities, but we have to have correct statistics, which we plan, helps us to plan, help us to make decisions. Well, I'm talking about abortions, for example. We have statistics, official statistics, and you know how many abortions we have in the Republic, but we don't know what is under the carpet. In private clinics, which do not report, which don't give us any information, and so on. But it's not correct. We have to know, and we have to influence on this. And this is for example, then when we just remove moles and some kind of skin defects, yes, and it doesn't fall into statistics. Yes, it's a big problem, and well. We have this. Let me just say something. In the Soviet Union, we had the medicine system with the employed people had to go through regular medical checkups in their workplace. Yes, situation changed. A lot of funded sector, but it's a problem now. Yes, we try to help big companies to screen their workers and provide medical checkups, we have the main task for us now is to streamline and personalize medical checkups. What I mean is that if somebody works in a company in a big plant and it's time for him to have medical checkup and we now unfortunately cannot see this how these programs work together. If somebody was had medical checkups and I mean he had checkups from different categories, and it's important that when private clinics participate, you know, I'm not against it, when they participate in these programs, medical checkups, they make money, but we have to get information about every patient. And this information must be sent to the polyclinic where this person is registered, in order not to distort this information, not to confuse something, not to provide this checkup twice. We try to do it. We try to organize this databases. This is a serious money which we spent. But if we spend this money must give result and feedback. It's not just decreasing mortality, but it must give good health to our people who work. So we are finishing. Always an indicator of the industry is business. If business works in this area, so that means this industry is working successfully in general. Is it profitable for you to work in the medical care system? Yes, of course. Yes, of course. I said that the tariff policy, like anyway, tariff policy is the foundation of economy. And of course, we have to be very careful about the tariffs and price formation, especially in terms of the private-public partnership. And at the same time, when we work with the government, we got job, and then this is my entrepreneurship and business task. What to do with this task from the government? So the business mentality helps us to choose high-tech solutions, and this is the stimulus for us to develop and to go to the on the outside and go to different markets and to go to the free market to make money in this area. And the doctors, the salaries, do you have the high salaries? No. Do you have a rotation? No. We had time when we got young doctors without experience, but they gain experience because of system of apprenticeship, internship, specialists, and so because of this policy, we have therapists, but we have 92 neuro specialists.
Max, could you please tell us if you are expecting to scale your experience of working with the Republic 38 polyclinics? It's probably not the limit on maybe moving it to other regions as well. And what solutions, what support is necessary for that? Well, first of all, we are not working in Tatarstan only, but in Tatarstan we see important support. I would like to give an example the way private company and public sector is cooperating. We noted that in the pandemic, Many people are suffering by staying at home. They were probably forbidden to visit polyclinics, etc. In that sense, we have offered polyclinics to organize their remote control for the most challenging groups, those who are in the most vulnerable groups. In that case, a nurse from the clinic number 7 is coming to the home where a patient is living, taking blood from finger and not a vein, and is getting a result immediately. And in the private room, electronic room, they are getting new dosage of warfarin. That is a collaboration when private and public sector started working with patients on telemedicine. This project is being implemented. We have seen positive feedback from patients that they have been there. In this case, doctor is not visiting the patient, but the nurse does, but is capable to do everything that is necessary. This project and many other projects obviously cause interest of great many regions. People from Tyumen, from Arkhangelsk, St. Petersburg travel to Kazan to take a look at other countries, Azerbaijan and Baku, visited MKDC and other medical centers of Tatarstan to take a look at the experience that has been accumulated in the Republic of Tatarstan. In that sense, Tatarstan is started becoming an example for other regions. So of course we are interested in working in other regions as well, but most importantly, it's not just cooperation with the Ministry of Healthcare and hospitals. It's also important to be working with medical universities, because where we work in line with the single protocols. We have first translated all the Dutch protocols into Russian, and then together with the team, after the aegis of Professor Kadamish, we have adapted Russian protocols with them. Those are important. In line with protocols, all doctors are doing identical work to guarantee quality of patient offering services to patients, which is why the symbiosis is important. And the interest of other regions has just stunned us, and I think that we will be maybe, I don't know, saying thank you to pandemics in the sense that it certainly pushed us to become more active. They also became the tenants of Innopolis. They registered here and they conduct all the activities already in the dimension of information technologies. Thank you very much. I will be wishing you success. We'll be rounding up our discussion. Primary healthcare is the window, the face of healthcare, because interaction of any patient with a doctor starts with a call or a visit, an appointment, or interacting with an ambulance. In case of private medicine, you wouldn't even want to go there because it is not easy to be the face, which is probably why private medicine wouldn't want to go there. Well, I would like to wish you success. I would, of course, wish all of you never have difficulties in accessing healthcare services and getting appointments, dispensarization, not just formalistically, but for the true knowledge. We've been talking with you, dear audience, and you, dear speakers, on the reform of primary health care and about the current state. Thank you very much for your attention. We are part of 100% Tatarstan.